I'm Sarah Treleaven. I'm a principal officer in the Department of Health, and I work on a number of Sláinte Care projects, and I'm here to talk to you today about one in particular, health regions, and how it is that that will change the landscape through which a lot of our health and social care services are provided. So just a bit of background and a reminder, because this has been a long road in terms of Sláinte Care. Sláinte Care, as you know, is all parties in Ireland have signed up to a 10-year programme of reform. It aimed to do a number of things. Most importantly, for the Health Regions Initiative, it advocated the integration of acute and community services, as well as the integration of health and social care services with other public services more broadly. It also advocated for a population-based approach to service planning and funding. Obviously, integration is really important. A lot of our patients and service users move between different parts of our sector back and forth. Again, they may have an acute episode of care, which then bring them to addiction services door or to some other part of community-based care provision. So at the moment, the patient or the service user is really the only single thread or unifying link as you move from community services to acute services and back again. And similarly, a lot of people enter into health and social care services because there are a number of health inequalities that lead them to ill health in one way or another. You all are very acutely aware of this. It advocated a population-based approach to try to bridge this integration gap, as well as to have a more evidence-informed approach to how it is that we plan our services. We know often that health inequalities there can be an issue with ensuring that patients and service users who require tailored or complex services can be underrepresented in our planning. And it has been kind of globally acknowledged that doing a more data-driven population health needs assessment and then service planning process is a way to bridge that gap. So all of this has then filtered into a number of policy documents that you see represented on your screen there. So obviously, firstly is the Sláinte Care report itself, and then as a way to try to accomplish or rectify some of the aims that I've just mentioned, health regions have been brought to the fore. So really, health regions are the mechanism through which we'll accomplish various different Sláinte Care aims and objectives. They're not a policy objective in and of themselves. Again, I've spoken to this a little bit, but there are a number of other Sláinte Care aims and objectives, things like eligibility reform, things like reducing our waiting times. And while these are important, and we would think that comprehensive or coherent geographies will be beneficial in helping us to rectify some of these difficulties that our services face, they're really integration and a population-based approach to service planning is the main focus for the Health Regions program. Everyone will know the tagline, the Sláinte Care tagline, right care, right place, right time. So, case for change. This map looks bonkers because it's meant to look bonkers. We have bonkersness in our system. Essentially, as you know, we've got 6 geographic hospital groups, we've got 9 CHOs, and then those are the links to a lot of Section 38 and 39 providers. So we have quite a complex system, quite a really bonkers is the word, yes. So the boomerang in the middle of the country is my favorite. So these structures don't overlap in terms of management, geographies, clinical or corporate governance, or budgets. So it's any wonder that we struggle in terms of integration. So again, health regions are aiming to try to rectify this. They're aiming to try to give us a platform, a coherent geographic platform that we can actually meet and talk about services in a more comprehensive way. The new map is here in the middle. So as I've spoken about, the strategic objectives for the regions themselves are to integrate hospital and community-based services. And when we say community-based services, we also mean other public services, education, housing, social welfare, etc., justice system. We're seeking to clarify and strengthen our corporate and clinical governance lines as we go through this process. Obviously, if we're introducing new entities onto the pitch, you have to consider the clinical and corporate governance lines that they will have. So while we're doing that, we're trying to simplify, clarify, strengthen those governance lines. We're looking to support a population-based approach to service planning and delivery, which aims to address health inequalities. So if we were trying to think about population-based planning, the idea that you could do that without even just being able to name and put a line around your population is quite difficult. So this is an important step towards that. We're looking to improve equitable regional investment and balance national consistency with regional autonomy. Jonathan just talked about local ownership. Oftentimes, frontline staff will come back to us and say that when they're looking to introduce a new initiative, it feels like everything needs to go to the top of the tree and then back down again before a decision can be made. So what we're aiming to do with health regions is balance that national consistency, which was the reason why the HSC was set up all those many years ago, against regional autonomy and local ownership. So it's trying to strike that between the two. You don't want things to end up in a postcode lottery sort of situation, or that it's the Wild West and everybody's doing things in a different way without any regard for what our national aims and objectives are. But in order to encourage that more local ownership, giving more autonomy to regions or more frontline, closer to patient structures is a way to go. Lastly, we're looking to run, obviously, a highly efficient, productive, transparent system as we do all of this. Okay. This is the map itself. So it doesn't have a boomerang in the middle of it, so we'd call that an improvement, I would hope. But this is the map that was approved by government back in 2019, and this is the map that we're working towards at the moment. As I mentioned, if we're introducing new entities on the pitch and we're shedding community healthcare organizations and hospital groups, if those are going to be dissolved in favor of regions, we do need to go back and consider what the role of the department, the center of the HSC, and health regions will be. So the department is really looking to provide leadership when it comes to policy, strategy, legislation, funding, and oversight. So as a central government department, that makes sense. Legislation and policy is the name of our game. Funding and oversight is written into the law. The minister is the one at the end of the day who allocates out the budget, so that's why the funding and oversight are there. The Centre of the HSC are really there to provide that national consistency concept that I was just talking about. Bernard Gloucester has summarized their role as PEPA. Planning, enablement, performance, assurance. That's what the Centre of the HSC should be doing and should be providing. And health regions themselves should be absolutely obsessed with service provision, so coordinating, managing, and providing integrated services at the end of the day. Where we are at the moment. So in 2022 and 2023, there was a business case regarding the health regions. Obviously, we had all been through a pandemic, and we needed to go back and make sure that this whole idea that was talked about in 2017 in the Sláinte Care report was still a good idea. Should we still be doing this? That's what the question of the business case actually asked. Should we be doing it in the way that it was originally envisaged, or has the landscape changed? So that was done in 2022. Following that, the answer was yes, that we should still be doing this. However, the Sláinte Care report advocated that the regions be their own legal entities. But because we had been through a pandemic, government decided that they probably shouldn't be quite that autonomous, because if they had been that autonomous through the pandemic, we may have had more difficulties in coordinating a national response. So they decided that they would be divisions of the HSC. And then they directed us to go away and do an implementation plan, which was approved by government in July and is available on the Government of Ireland website and the HSC website. So that was done conjointly with the HSC. The regional structures are being decided as we speak. So what will the actual structure itself look like within a health region? I should say that while we're making these decisions, we're quite conscious that structure is not the end-all be-all. Structure is not going to accomplish integrated services or population-based planning in and of themselves, but rather they're trying to get out of the way of being able to do those things, get our structures to be more coherent and out of the way of those overall aims. So we're entering into quite a fundamental year in 2024. So firstly, the regional executive officers will be appointed. So there will be somebody at the top of the regional tree, if you like, and then staff will be moved in underneath him or her in each of the 6 regions. CHO and hospital group leadership for this year will be reporting into that regional executive officer. So that is a change. Right now they go into the director of community operations or the national director of acute operations. So that'll be a shift in Q1. We'll be realigning the geographies. So CHO1 and CHO8 are the most affected by this regional change. So there will be some movement of staff and services in those particular CHOs. There will also be movement of the governance of particular hospitals to create that more geographically coherent region that reports into that regional executive officer. In Q2, we'll be rolling out the integrated service delivery model, which is being developed up by the HSE as we speak. And we'll be looking to revise the processes that govern our system, the service planning process, the corporate planning process, etc. In Q4, the leadership of the hospital groups and CHOs will be stood down. So we are in a transition year next year. Okay. I might talk a bit about, again, those two aims for just one quick minute, if you'll allow me. So in terms of integration of care, integrated service delivery, this really is pointing out that the point at which our acute services and our community services integrate in terms of managerial or budget is the Chief Operating Officer of the HSE. It's quite high up there. So if it's any wonder sometimes that we struggle to secure beds for addiction services in acute and community services, because those are funded through separate lines. They're governed through separate lines. So they don't have a heck of a lot of incentive to work together or integrate. This is the theory behind the policy in and of itself. What we're trying to do is push that down 3 or 4 layers within a health region. So that's what we're aiming to accomplish. So in terms of integrated service delivery, it is foundational so that we can have right care, right place at the right time, and that teams are working together and are incentivized to work together in managerial and financial terms. We're looking to incentivize care at the lowest level of complexity, understanding that sometimes that is quite a high acuity for some of patients and service users that we encounter. It's really central to delivering health regions itself and changing the way in which we deliver services. I've stolen this boldly from New Zealand with their permission. This is really a map or concentric circles that represent different levels of acuity of care, and what we're really after is blurring the lines, as you can see in here, and not having quite so many lines between different types of services as we move into a more integrated model of service delivery. So it's one of my favorite pictures. Lastly, I'm going to talk about population-based service planning. There's a couple of more concrete things around this that might be of interest to the audience. So, 1 second. So in terms of implementing a population health management approach to service planning, what do we mean? We know that services around the world face difficulties when they're trying to provide timely, affordable, equitable access to services. And this is particularly true for marginalized communities or patients or service users who have really complex or multifaceted needs. Planning services around them is just inherently difficult. There's been some consensus that doing this population-based approach to service planning, doing a really systematic, data-driven approach to assessing the needs of a population, putting that out there in a very transparent way, and then orienting your service planning around that is a way to try to address these things. It sounds really simple. It sounds like we should be doing it already, but we all know that sometimes our service planning can be a bit of a convoluted process. And it doesn't always have a real solid data-driven evidence basis for identifying and then addressing those population health needs. Catherine Hayes did a position paper in Trinity College Dublin about a year ago, and I've borrowed this with permission from her paper. Essentially, what we're looking to do in terms of introducing this population-based approach to service planning is putting in the infrastructure to do it, to actually change the orientation of thinking around how it is that we plan services. So there should be shared leadership, defining our population, as you've seen on the maps, we're working towards that. Agreeing an information governance structure and agreeing what we mean when we say that we're assessing the needs of a population. And then having the analytical capability and capacity to do that. Then once you have all that in place, what does it feed into? It should be feeding into understanding our population profile and reviewing and prioritizing the needs that capability identifies. And then, again, making those really transparent so everyone can see and can look at and agree what our population health needs are. And then lastly, it's deciding what it is that we're going to do with that, letting that factor into things like political priority setting, letting that factor into things like resource allocation, either revenue resource allocation, capital resources, or workforce resources. So that's what it looks like. That's what we're trying to accomplish, and look at what it is that we need to put in place for the infrastructure, the intelligence, and the intervention side of introducing this new way of service planning. I've talked about it here, actually. And this is done at a couple of different levels, at a neighborhood level or a community healthcare network level, at a place level, which would be kind of analogous to our regions, which roughly have a population between 400,000 and 1 million, and then system-wide. And there's been some thinking done on that revenue side of resource allocation in the context of a population-based approach. So there's been a couple of different spending reviews that the IHS economists, the Irish Governmental Economic and Evaluation Service economists, have done for us in looking at what a population-based resource allocation model would look like and what sort of variables should go into that. They did 2 papers for us last year. One was about an international review of how other countries have gone about introducing this, what variables they included, what their governance structures were like, what did they do, how did they do it. And then the second was taking those and applying those to Ireland, and then taking that to our actual budget of 24 billion and saying what would be the approximate budget for each region. So those have been published and have been very interesting and provocative for us. What the international literature said to us was that keep it simple, stupid. Do not put too many variables into your resource allocation model at the first instance. Use as many census-based variables as possible, and try to actually avoid using too many variables or data sources that are generated by the health service themselves, because then you create perverse incentives and gamesmanship. So the model itself that was proposed by the IHS economists looks at the size of the population in each region, the age and sex breakdown, a deprivation index, the public deprivation index, and a rurality index, because we know that there are particular challenges and sometimes additional resources required to provide services in more rural environments. And it introduced one other one, which was self-reported health. So that was the only health variable that you could say within this. So what it found is this, and it said that each region would have a budget of between 800 million and 2.3 billion. Again, depending upon the size. Area E is the Midwest, and it has the smallest population size, so it has the smallest budget. Area A has the biggest population size, and therefore the biggest budget. And that was slightly weighted again by those variables that I talked about: age, sex, socioeconomic status, rurality. So I'd encourage you to go away and take a look at those papers. They're wildly interesting. Okay, so that's my presentation. So thank you very much. Okay.